All right. So I want to welcome you. I'm talking to people in the room now, but to our next session, which is given by Christopher Trower, What to Say versus What Not to Say, Culturally Competent Communication. And Chris, I'm sorry, did I just mangle your last name? Can you?
It's okay. It's Trower, but you know.
I'm sorry. Okay, Chris Trower. I was like, oh, that didn't sound right. So Dr.
It's okay.
All right, go ahead. The floor is yours.
Well, good morning. So my name is Chris Trower. I'm originally from Richmond, Virginia. I went to Hampton University for undergraduate and grad school, went to medical school at the Edward White College of Osteopathic Medicine in Blacksburg, Virginia. And now I'm currently a PGY2 resident in the best specialty of physical medicine rehabilitation here at EVMS. Really glad to be a fellow in this fellowship program. I'm looking forward to presenting my my research project. Let's see. Okay, here we go. All right. So kind of a little bit about EVMS. Like EVMS is located in Norfolk, Virginia. It's home to the largest U.S. naval base in the world. There's over 419 residents and fellows, 15 ACGME accredited residencies, 15 ACGME accredited fellowships, and then 8 other GME training programs. So I would be remiss if I didn't mention the people who have been helping me along the way, my chair, Dr. Park Savage, Dr. Fanning. Really grateful for all their help and coaching throughout this process. And next, I will talk about my learning objectives. Let me move this out of the way. Okay, learning objectives. So first, develop culturally competent medical professionals, understand how to address cultural differences professionally and appropriately, explore the awareness of cultural differences between provider and the patient encounter, and facilitate education on how to successfully navigate cultural differences. So I wanted to start off by doing kind of a pre-assessment survey. Can you all see the link? And I wish I had a QR code.
Put it in the chat.
Put it in the chat?
Yeah, okay. If possible.
Sure.
Or I can try to do that myself if I can do it.
All right, I'm gonna stop sharing so I can get out of that.
Okay. Do you know if it's the same one that was sent through, Ben Gap? Because
no,
it's a different one. Okay.
It's a different one, yeah.
Okay. Yeah, if you can, and then if you can open, show it again, and then some of us who don't have access to a laptop right now, we can just put it into our phones too. But okay, so Chris, put it in the chat board. And then maybe just when you go back to share screen, just put it back to that link again, and then we can, some of us can access it through our phones, our personal devices too. Okay.
Okay.
Let's see.
Yeah.
Okay, great. Yeah, hold on to that for a second, and then we can access. All right, we've been able to complete it, those of us in the room, so you can probably continue.
Okay. All right, sounds good. Thank you guys for completing that. So I figured I'd start off with some of my own personal experiences with cultural competency. So so the one that says on the right, it says good slave genes. So I was in a different residency program than I am now for my intern year. And a group of residents and fellows, we were all sitting in the residence lounge talking about golf. And, you know, one of the gentlemen in the group was talking about how another gentleman who was of African-American descent could really hit the ball far. And then one of the fellows at that point in time then said, oh yeah, it must be those good slave genes. So the reason why I felt like it was necessary for me to share this story is really because that encounter is kind of really what prompted me to create this module, because I wanted to make that story more of like my success and not something that I guess or a situation where I felt uncomfortable, and it's kind of like somewhat shaming myself in a way. So I wanted to bring light from that situation, even though it wasn't a really great feeling to go through that. And then the left, the Hispanic patient on insulin. So when I was on inpatient rehab, we had a gentleman who had came after having a stroke, and he was on very high insulin requirements. But as we all know, in the hospital, we're like regulating their diet. And then in rehab, he's doing a lot of exercise, more exercise than he probably did at home. So we were gradually titrating down his insulin, but then it came time for the decision of, what insulin regimen is okay for us to send him home on. So from my previous experiences with medical mission trips, going to different Hispanic or Spanish-speaking countries, I was thinking of what his actual diet might be. So I went and asked him, like, hey, like, what do you want to eat at home? What are the types of things you're eating at home? And he was telling me that, it's pretty much consistent with what I suspected, which is more of like, rice, lots of beans, lots of tortillas. And he eats a very carb heavy diet. So we decided, instead of sending him home on the insulin that he was on in inpatient rehab, we decided to send him home on the insulin that he used at home, because he was resuming his home diet, his home exercise regimen. So that's kind of like a way that cultural influences kind of influence our medical decision making on inpatient rehab. So first, we'll start off by defining culture. Culture has been defined as an integrated pattern of learned beliefs and behaviors that can be shared among groups of individuals. It can include thoughts, styles of communicating, ways of interacting, views on roles and relationships, values, practices, and customs. So I guess the next step will be like, what is cultural competence? And cultural competence is the ability to collaborate effectually with individuals from different cultures, which, as you can see, that collaboration kind of resulted in a different medical decision, as opposed to not collaborating with that patient and deciding that proper next steps were going to be for him. The cultural landscape. So the United States has been undergoing an unprecedented cultural change, really been trending back for many decades now. But in 1995, there was an article, it was forecasted that in 2050, the Asian population will increase from 3 to 11%. The African-American population will increase from 12% to 16%. And the Latino population will increase from 9% to 21%. And the next point, minorities will become the majority by 2024. And by 2060, approximately 20% of people in the United States will be foreign-born, which is a pretty significant point from two standpoints. One, that it just means that our patient population is going to really start to look a lot differently in these upcoming decades. But that also means that hopefully, which I think what BenGAP is trying to accomplish, is that the physician population will look a lot different as well, so that we can kind of combat this and make sure that we are all remaining sensitive to our patients and being able to use those differences to create a better collaborative relationship between the two of us. So throughout more of the research I was kind of doing, the lit review, I found these 3 zones. And to the right is the picture that I have from the article right there. So the 3 zones, so the surface, cultural competency, which would be people who have minimal knowledge of cultural competency. In the article, they described it as like people who kind of just live in the light. So like the very top surface of the ocean, it shines light into the water, but they don't look deep down underneath what they see. All they really go off is what they see. So they don't really know as much as other individuals who have looked a little bit deeper within themselves and looked deeper into actually cultural competencies and what it actually means. The next zone is bias twilight zone. It's a person that begins to look at underlying biases that they personally carry, which, just being completely frank with every one of you, is I thought that, that I was doing really well by just being in that zone. But from taking a look back and really like looking at myself, I was like, I didn't even realize the 3rd zone, which is confronting midnight zone is a person who then looks at how their societal position influences their outlook. And I think that's extremely critical as physicians, future physicians, because as a physician, we have a lot of influence that I think I really just didn't pay as much attention to. But in actuality, when patients come to the hospital or come into our clinic, they're going to make life decisions based off what we tell them. And that's having a strong amount of influence. So we really have to make sure that, even though we give this gift of being able to take care of patients, that we're doing our own due diligence to make sure that we remain cognizant of the influence we have on people and the things that they decide to do. So cultural competence education in recent years. So it's been kind of ongoing for decades. Some of the literature dates back to 1987. Since then, there has been many tools to assess cultural competency in an effort to reveal deficits in the medical community. Example would be the inventory for assessing the process of cultural competence among healthcare professionals, IPAC, which was developed in 1999. So right here, what I have pictured is a past resident-led module, which this schematic is kind of the result of their research. And so it was developed by the physicians in the internal medicine department of LSU. And I'm going to talk more about the schematic on the right. So it's kind of divides it into 4 different pieces. So you have education, communication, activities, and rotations. Education is kind of similar to what we are doing kind of right now, like a workshop, skill-based workshop that people and providers can undergo and try to learn more about cultural competence. The other part, which is the second part, would be communication, like having those types of dialogues with people to try and better understand each other. Third would be activities. So trying to, really involve yourself in activities with people who have different cultures than you, and then trying to understand how those activities influence their own personal decision-making, influence their well-being. And then fourth is rotations, like doing away rotations in a different country or a different part of the world. I know me personally, coming from VCOM, I was able to do a rotation out El Salvador and Dominican Republic. And those rotations I was able to really more understand not just the cultural dynamics of Hispanic culture, but like the interpersonal dynamics of families and like communities. And that's a whole different level of understanding of a person when you really understand like their family dynamics and community dynamics. Other past resident-led modules, so Atkinson et al., they evaluate cultural competence via cross-cultural care survey. And through that survey, they observed residents or physicians and patients. They gave the survey to both. So they found that residents who view themselves as more culturally dexterous were likely to self-identify as non-white. And when compared with patient responses, white patients were more commonly to report highly dexterous care, and Black patients were more likely to report poorly dexterous care. So the need for cultural competency education. So healthcare disparities have grown to become glaringly obvious in recent years. Some that are well known are worse pain control, decreased access to medical care, more complications postoperatively, and high mortality risk. However, while addressing these issues listed above, a more immediate way to fight this disparity is to just work on how we communicate with people, like the patient-provider dialogue. And an article I found by Shepard et al. Illustrated that their findings that there's a need for cultural awareness approaches in healthcare. So my first case, so I didn't really explain kind of how my module set up. So my module set up, I have 4 different cases, all kind of based around different situations that will require cultural competence. And one of them is kind of more based off of an actual like real life experience as well. that requires cultural competence as well. So the clinical setting is you're a resident physician or your outpatient continuity clinic rotation. Your attending tells you that there will be a new patient coming to the clinic after the recent admission to the hospital, and that you will be assigned this patient. A 25-year-old African-American female with no past medical history presents to an outpatient clinic to establish care with her PCP. Past medical history, past surgical history are non-significant. She's only on oral contraceptives and multivitamin. Family history, mom and dad. Mom had no medical issues. Dad had hypertension. No known drug allergies. She's not currently sexually active. No illicit drug use. Drinks about 2 to 3 mixed cocktails on a weekend, 1 time a month. Objectives. So overall, her vital signs were stable. Her physical exam was overall unremarkable. And so with your assessment plan, you tell her to continue to follow up with you annually. So upon finishing your clinical encounter with the patient, you notice that she has a unique ethnic hairstyle. So there's no poll. This is just kind of like a question to kind of self-reflect for your own personal reflection. So what is the appropriate way to compliment her hair? I'll give you guys like about 30 seconds to consider. Okay, so.
Hi.
You have to do something there, but I don't know what it is. Okay.
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 Is it better?
Yeah.
Okay, I'm so sorry. Hi, I'm Joanna. I'm a student in person. I'm using Dr. Abali's laptop. Am I
okay.
echoing?
Yes.
Is it better? No.
All right, let me see.
He was doing something. Let me just-
Okay. So,
Hello?
yes.
Yeah. Anyway, I was going to say A.
Okay.
The chat. There we go.
Yeah, I'll look at the chat. So. Okay. So the correct answer for the question, let me see if I get all this stuff out the way, would be E, which is none of the above. So the ideal course of action is to avoid commenting on a patient's hairstyle, even if you find it to be beautiful, because we are in a clinical environment and our dialogue should be directed towards the patient's chief complaint. Of course, if you start to develop a better patient rapport down the line, that compliment may or may not be received. But initially, first encounter should be kept completely professional. Asking to touch someone's hair while concurrently touching their hair is a violation of their personal space. The hair is attached to the person's body, and consent should be clearly given before touching the patient. If a medical complaint involves the hair or scalp, then you can ask the patient before beginning your exam if that's okay with her, that you inspect her hair or scalp. Okay.
Okay. Hello? Is it?
Yes.
Okay, we got
Are
it.
we good?
No.
No?
I mean, we already moved past that case, but I guess maybe.
You can
I thought it was-
comment now.
I mean, I understand the reasoning why like E is the answer, but I thought in some situations, maybe because rapport hasn't been built, that it'd
Right.
be okay to compliment hairstyles as long as you're not attempting to touch someone.
Mhm. Thank you for your input. All right, case number 2, Asian descent.
Sorry, were you able to hear Joanna's comment?
No, I did not hear
Oh.
Joanne.
I'm so sorry. She just had a comment about it.
Sure.
Right.
Try again.
Oh, can you hear me?
Oh, I heard your comment. I'm sorry. It says
Oh, yeah.
Emin. Okay, I heard your comment.
Joanna is
Okay,
using
okay.
Emin as
I
Got
didn't
it.
know you're
Thanks.
Joanne. I just read the bottom name.
Go ahead, Joanna. Oh, okay. Sorry, Chris.
Yeah, I heard her comment.
Okay.
Oops. Okay. Okay, so clinical setting. You are a resident physician working with a medical student who's doing a rotation with you. It's internal for General Hospital to get on-the-job training before their graduation later this year. The student learned from you is of Asian descent. You and your student enter one of the patient's rooms to provide care, and this is how the conversation goes. Let's see if I can. You, good morning, Mr. Wood. Student, good morning, Mr. Wood. My name is X, and I will be following along to learn. Is that okay? Patient, good morning. Yeah, that is okay with me. Patient, so X, are you Chinese? And student, no, Mr. Wood, I'm not Chinese, I'm Korean. You finish up the clinical encounter and you exit the patient's room. What is the next most appropriate step to do?
Hi, it's Joanna again, using Dr. Abali's laptop. I was going to say that I think that in this situation, I assume the correct answer would be B, to ask the student how they're feeling about the encounter and if they want to talk about it. Although I feel that this may have been an opportunity to talk to the patient about such an interaction, or rather to defend the student in that clinical encounter. I'm not sure, maybe that's like pushing it because you're trying to provide care for the patient as well. But I feel that in that opportunity, just say to the patient that asking where someone is from is different from making an assumption based on appearances.
100% agree with you. I'm actually going to talk about that later. Don't steal my presentation. All right. Yes, so you are correct. Correct answer is B. The patient calling the student Chinese is culture insensitive on the patient's part. People of Asian heritage are very diverse in their backgrounds, traditions, and languages. So to label a person as Chinese due to their appearance is considered disrespectful to them and harmful to them, actually, to their heritage. So the next question is, what was the appropriate action during the encounter? I think Joanne answered the question for us all. So I will go to the next part. So the correct answer is A, inform the patient about the cultural insensitivity of their comment and provide education. Sending the student out of the room not only inhibits the student's learning, but sends the message that the student could have done something wrong by correcting the patient, telling the patient that she is Korean. Just like Joanne said, it's like this is an opportunity for us to say, hey, like, and create that dialogue with the patient so that we can actually help to educate them. And also just to make sure that our colleagues that are training, then make sure that they're okay as well, and stick up for them in those types of situations. Case 3, which is identity. So clinical setting, again, you are the resident physician on your outpatient continuity clinic rotation. Your attending tells you that there will be a new patient coming to the clinic after their recent admission to the hospital and that you will be assigned this patient. Alexa Amazons is a 34-year-old female, past medical history, only significant for asthma, with recent admission to the hospital for an asthma exacerbation, not requiring mechanical ventilation after going on a hiking trip in the Appalachian Mountains. Upon arriving in the room to conduct the clinical encounter, you observe a young appearing male with a beard, dressed in tight pink shirt and skinny jeans. What is the most appropriate next step? Can everyone see this? I feel like the names are in the way.
We can see it.
Okay. Okay, so next we will do, all right. The correct answer is C. Introduce yourself and ask the patient how they would like to be addressed. Introducing yourself is how providers normally begin their clinical encounters, which is how every encounter should begin. Asking your patient how they would like to be addressed is a very appropriate question to ask patients. Older patients sometimes may prefer to be called Mr., Mrs., Miss, and some less formal patients will want to be called by their first name. Patients who are transitioning, have undergone gender reassignment surgery, or just prefer to express themselves differently than the perceived norms of society want to be treated like another patient in your practice with respect to their personal life choices and decisions. Furthermore, asking the patient how they would like to be addressed allows the patient to identify how they would like to be addressed without the provider explicitly asking about preferred pronouns as the first question, because often these patients will inform the provider the pronouns they prefer. If the patient does not say the preferred pronouns when asked how they would like to be addressed, asking preferred pronouns is an appropriate follow-up question to ensure you're being sensitive to their own personal gender identification. So to further explain some of the incorrect answers, so introduce yourself and conduct a clinical encounter as normal. This answer is incorrect because continuing the encounter by calling the patient by a name or pronoun that is not preferred can be as insensitive and or insulting to the patient if they don't identify with the pronouns associated with their name. Another explanation for B, introduce yourself and ask the patient whether their preferred pronouns. The answer is incorrect because by assuming the patient has preferred pronouns, a provider could be making an incorrect assumption based off their physical appearance, which can also be detrimental to the provider-patient relationship. Although some patients may prefer this question, it's important to ask an open-ended question that allows the patient to identify how they would like to be addressed to avoid any assumptions. And then my last case is, hey, sweetie. So this case is the clinical setting is you are a female resident physician on your emergency medicine rotation in week 4 of an 8-week rotation with an attending you have worked with many times before. Attending, hey, sweetie, do you mind seeing the patient in room 5? The nurse just told me the patient's having abdominal pain and I would like for you to do a physical exam. Resident, sure. Do you want me to go ahead and just pick up the patient? Attending, no need, just go lay your eyes on them, do your exam, and let me know what your thoughts are. Resident, we'll go see the patient once I finish putting in my orders from the patient I just saw. So what about the scenario could have been improved?
Hey. Oh God. Okay, sorry. Sean again.
See.
I will say B. The attendant could have addressed the resident as doctor, insert name here. No one should ever say, hey, sweetie, in the hospital, please, ever. Even if your husband is your attending, if you're in the hospital, don't let him call you, hey, sweetie. Okay, that's it.
Correct. See. Okay. Yes, the correct answer is B. The attending could have addressed the resident as Dr. and whatever her last name is. Using pet names such as sweetie, hun, honey, sweetheart, etc. when addressing male or female trainees, whether it be pre-medical students, medical students, or residents in lower PGY levels, is inappropriate and unnecessary. The training environment is a professional environment, and all persons in this environment should be addressed professionally by using doctor or by addressing the person by their given/preferred name. Incorrect answer or explanation for A. The resident could have gone to see the patient immediately when asked by her attending. Most times there's no need to rush or delay patient care. It's okay to take at least 5 minutes to finish putting in orders for a patient in most situations. Okay, so for the wrap up, so according to AMC Physician Specialty Data Reports from 2008 to 2020, the percentage of women in the physician workforce has increased from 28.3% in 2007 to 36.3% in 2019. Per the AMC annual report on medical school enrollment in 2019, it showed that the majority of U.S. medical students are women, which comprises of 50.5%. So in conclusion, the physician workforce is consistently evolving. So with that, we need to make sure that we're all staying steadfast and remaining to work hard to make sure everyone feels included and respected in our professional work environment. And if you guys do not mind completing the post-training survey right here, I can copy and paste it into the chat too as well. 1 second.
Yes, please do that. Thanks.
Thank you all for your participation in my module. But once you finish the survey, that's all I have for you. So thank you.
Would you have a few minutes for us to field some questions, Chris? Is that okay?
Yeah, for sure. That's fine. I just want to know that's it for all I have.
Well, thank you. I just finished my survey, so I'm going to go first. Let me just let some more people into the waiting room. Thanks, Chris. I thought that was great. I kind of marvel at how this, it's a little bit maddening too about how this continues to need to be reinforced. And even in our day and age, I think still like I'm reminded of sort of microaggressions that I face, but I'm also humbled by ways that I think that I can continue to grow and learn and improve myself. One thing that I kind of felt, and I wanted to ask the group about this, starting with you, Chris, and the rest of the group is, in a lot of those scenarios, they reminded me of things that I have sort of lived, right, and experienced myself. And there were so many times that I just kind of like held it in and was like, well, but, I've had patients call me hun and sweetie. I've often, patients will ask me where am I from? I sort of live those scenarios, and my sort of experience over the years has just been to kind of swallow that and be like, just accept it and move on. More so when patients do that to me as a provider. And I was just curious as to sort of how the rest of you have handled it, and I know that it's not necessarily right in terms of like how I've been treated, but in my response over the years to just sort of accept that is like, I don't even know like how I would begin to kind of unpack that and sort of move forward rather than just sort of saying, just accepting it and moving on.
I mean, it didn't happen to me because I'm not a physician, but it happened to me, people saying like sweetie or han, like stuff. But I did not do anything because I felt that they were not aware of what they were doing, and I did not correct them. Like when people are coming and picking up the garbage or something like that, or cleaning the floors, that happened to me a lot. But maybe I should have said something, but I never said anything.
Yeah, I think that it gets difficult I think the lower, and especially in medical education, the lower on the totem pole you are, it gets difficult to defend yourself in certain situations. So like as a third year medical student, I would just let things pass because I'm trying to get a good evaluation. Now that I'm a fourth year, like there are certain things I'm just like, I'm not going to put up with that. So I'll say like certain things, but not as many things I would say as if I was a resident who actually has like a job. So I think it's a little bit difficult depending on where along the trail of education you are. And I think that's where having a culture where people, especially like the attendings residents you are working with, know to address these things or to debrief or to pull you aside and talk about these things, talk to patients about comments, will kind of make the environment a bit more comfortable. Because even as far up as you go, there will still certainly be people who won't feel as comfortable defending themselves or advocating for themselves in these situations.
I can say so, kind of, I guess a little different, but the story I shared in the beginning about the good slave genes. That situation happened. I really was not able to provide education or respond, just because I was just shocked that somebody really felt so they felt righteous in what they were saying. Like he said it with such just confirmation in his head that this is okay. And I think for me, it just took me aback so much that I really didn't know what to say. Because I've experienced other comments been said to me, and I usually am able to, point out that, wrong thought process to that person. And then they appreciate me for doing that. But for that to just be just so blatant and so disrespectful, I just really didn't, I did not know how to respond to that. So I didn't say anything either.
I'm not a physician, but in the office of GME, Dr. Charles, I think it's amazing with microaggressions and then the work that we are doing on different levels. It really depends on how safe you feel in the environment and when you weigh the risk of even responding to different microaggressions, because it's an everyday phenomenon that you are inherently experiencing every day. And so it really depends on the safety that you feel, where you are, like she mentioned, and the risk to you personally that you feel. But it's really interesting to look at those reasons and why that with cultural competency or with microaggressions, we don't use our voice, or what's necessary to exercise your voice. Because when do you do advocate for yourself? When do you do correct? You find yourself always being the teacher or the corrector. When do you exercise your voice? And so it all comes down to me to your risk of harm, the risk of harm to you. And that's just something I think has to be evaluated more when looking at trainings with even cultural competency is the level of risk that the individual feels.
That's such an important point. I share that sentiment. And I think that, there's risk and safety. And then there's also kind of I think you're acknowledging that there's sort of a cost to speaking up and a cost to doing what's the right thing. And I think, we're all sort of trying to teach ourselves about what the right thing is and to feel comfortable with doing that. But the fact of the matter is that there's still the environment around us, the context, and there's absolutely a cost to that. If nothing else, at the most petty level, for me, sometimes the cost is just like, I'm tired. Like, why do I have to teach this? And obviously sometimes the cost is much greater. But thank you for pointing that out. Any other questions or comments for Dr. Trower or for any of us? Okay, well, if not, then I just want to thank you again, Dr. Trower. I thought that was fabulous. I think this is such an important conversation to continue. So I think every opportunity to do that is valuable and certainly worthwhile. I'm trying to find Mike. there we go. So I can make my little reaction. So thank you all. Thanks.
Thank you all.
Enjoy the rest of the
Thank you.